what time were the students supposed to come here? Come here by I think 8:30. How many are from out of Mumbai? Raise your hands. Okay, so all of you have hostel accommodation by now? No! Okay, anyway, students are still trickling in. We were waiting for everyone to assemble, but I think since we are running short of time, we'll start. So today we are going to have a lecture on end of life care. Now, this essentially, and also palliative care. This is a sort of a new topic maybe in the last decade or so. So it is very important, and as you will go through your MBBS curriculum, through your first year subjects, second year, then clinical postings and everything, you will get to know more about this. But in this foundation course, we are introducing everything, like sports, yoga, computer skills, communication skills, so on and so forth. So this also forms a part of it. Another part that Madam will touch on, Madam is Dr. Nandini Vallath. Madam has done her undergraduate and then she has post-graduated in anesthesia. Madam has specialized in neuroanesthesia, after which she moved on to palliative care in 2007. So more than a decade ago, Madam has lots of experience. Madam is heading the quality control in the TATA Memorial Center. That is, there are having 20 centers spread all over India, and she is also a director of the palliative care unit there in all those hospitals. Additionally, Madam is also a consultant in the BRC. Madam is on various committees. Madam has published so many papers. So there's lots that you can look up to Madam and try to.
She is now our consultant.
Madam is also recently a palliative care OPD was started in these twin institutes. These twin institutes, of course, are the SETH Medical College and KM Hospital. And talking about this institute has been aptly described as Maji Ai by former dean of ours. So you should have a lot of, you people are very lucky to be here. You people should be proud of these twin institutes, which are SETH Medical College, KM Hospital. So, Madam is going to touch upon topics of palliative care as well on, I think, medical ethics and a little bit of communication. I think I'll hand over, and like I was saying, that you have lots to look upon, Madam, so try to emulate people. So I think I'll hand over to Madam. You can cheer her with the claps. Madam has actually been very instrumental in changing government policies. Also, there were government policies related to narcotics and analgesics. You will come to know as you go by your course, and how to how much can we use them or where can we use them. So it is required to elevate patients of unnecessary pain and suffering. This is the part of palliative care that Madam will be touching upon. So this requires, of course, a complete government backing and the change of rules and laws, about how they are dispensed, how they are used and all. So Madam has been on all those government panels also, and Madam I think has done some work in WHO also at Geneva. Okay, so I hand over to Madam.
It's great to be here and seeing all of you, and it was good to see that so many are from outside Mumbai, and so we have a really mixed experience of growing up. Because in a metro, the way the children grow up to be where you are, and how children grow up in outside of a metro are very different, and there is so much to learn from each other. And I'm going to look upon this lecture as just a sensitization of you are doctors already. It's just that you're going to build your capacity, and we should always retain that humanness, the humanity within us. When we are seeing patients, we don't see them as liver or lung or pancreas walking to us. We see them as human beings with these organs and their own thoughts and requirements and priorities. So that is my main intention, and so I would like to begin with this. So this is my way of flowing through this. Maybe now 45 minutes we have, of which I hope I take less than that, so that there is some time for questions. So we just look at generally, the life as a series of experiences and illness as an experience. Then we look at, because we are going to learn to be doctors, we look at how we can improve the experience of an illness. And then I will talk about the core subject. Hopefully it will lead to it by the time we reach there. And then what roles are as a medical student. You have so many years of working hard, studying and learning. How can you, develop your antenna to pick up the right things as you learn and as you go through these 5.5 years? So beginning with this, all of you must have heard about this. The CCD king commits suicide, and this is, his suicide note. And there's a statement there: I gave up as I could not take any more pressure, and he felt that he was a failure. See, death is the ultimate consequence of all that what we want to prevent by being doctors. Now, this person was physically very healthy, but there was something that was not healthy in him, which led him to, think that his healthy body, everything else was, it wasn't worth living for. He also mentions in his suicide note that there are enough assets to pay back everything, but we really don't understand why he actually committed suicide. Maybe a bit of help at that time, maybe some conversation could have preserved this wonderful entrepreneur. The second part is all of you have heard of Stephen Hawking? Yes. And you know that he had hardly 5% of his muscle power. And I happened to read this book, and I was reading the preface of the book. And he states in the preface, there is one paragraph, it states that other than the minor physical illness that I have been very lucky. So, to think that just having 5% of your body working as a minor illness requires an identity of yourself which is beyond physical. You understand? So this is one of the experiments that he gave himself up for in the space experiment. He volunteered. So look at the way he approached life. So this brings me to the definition of what we are considering as a good life. Is it healthy body? Is it wealth? Is it mental power? It all depends on what we identify and how we want ourselves to be validated. So I'm bringing in all these thoughts because when we see a patient as patient, we drop a lot of these aspects from our point of view. I'm just requesting you, because you are fresh from your background, you will still see people as people. And over the few years, by the time you are interns, please try and retain the same viewpoint of wonder, curiosity that you are having today while you are sitting in the foundation program of first MBBS. So now, I'm going to just listen to something that I have brought. I hope it plays. Where exactly do we have these experiencing of our life? So I have brought in, I don't know whether it will work, let me just try. Yeah, okay. Are you able to hear anything? So this was a Basuri by Hariprasad Chaurasia, and did it elicit a particular mood in you? What was it? I mean, just if you can. Pardon me? Peaceful. And something positive, right? It was anything else? I didn't hear that. Louder, please. Calmness. Okay. So something calm and peaceful you heard. Now, let me try another one. If you can have a little higher volume, is it possible? थोड़ा volume बढ़ा सकते हैं?
ये knob है volume से दिखे corner.
अच्छा ये बात.
Yes.
Okay. Now there is. different raga. So did it elicit any other? What is the mood that it was? Little sad, melancholy. So where did this happen? Did it happen in the liver or in the lungs or the brain? I just play this to let you think that experiencing is something very different from organ health. So this is just to get you into coming with me in this talk so that we understand what we are talking about when we say caring. Because as doctors, we are expected to cure, care and comfort. So you will hear a lot about curing right through your curriculum. And at the same time, simultaneously bringing this aspect of caring all the time, watching your teachers, how they interact with patients, how they respond, and what not to learn, also very important. Some of the teachers will give you excellent attitudes and you will carry with you. Some of them may not be doing as per what you think should be done, but hold that also and learn from it. So that is the whole idea. So now let me move on to... So that brings me to the definition of WHO on health. So it's a state of complete physical, mental, social well-being and not merely absence of disease. So in Indian language, we have the word arogya as well as swasthya, as health. Arogya is absence of disease, there is no roga, whereas swasthya is well-being. So there is we need to understand these two differences, and then we will now move on to how these experiences, every event, a marriage or growing up or even getting into medicine or passing out as an MBBS doctor or doing an MD, everything is an experience. Just like that, even an illness is an experience. Now when we meet a patient, we will meet them in an acute setting, like child Ashish who has a pneumonia. So you examine, and then there is this Ahmed who is paraplegic. Both are difficulties, there are conditions, illnesses, and how we approach them. One is of course treating the pneumonia, giving them antibiotics, handling the fever, and following up, etc. Now in that respect, he was normal, Ashish was normal to begin with. Then he developed the infection, his health fell. And then after the treatment is done, he gets back to normal and he's back to school or whatever else he needs to do. There is not too much of disturbance that has happened in his life except for that few days when he probably missed his classes. So this is something like acute illnesses and how we look at it. Now if you move into some other acute conditions, they don't end there. Like myocardial infarction, when a person has part of the heart which is not getting enough blood supply, or they have cross burns where most of the body, or major accidents where they break their limbs or have difficulties. This is an acute illness also, but after discharge, they are not completely back to normal. They may have their own disabilities and they continue to need care. Now, you should remember that all hospitals are built with the idea of acute illness. There is no system in place for patients once they are discharged to access much help. The things are changing, and that is the reason probably why I am here today talking, because I'm sure 5 years ago we didn't have such classes. And also we are having now palliative care OPD, and probably by the time you reach your clinical posting, you probably have rotations to these different things. So we may have a system in place by the time you graduate. So we need to understand that taking care of, I'm just focusing on one of those conditions, like when we look at these patients, they may present and they may respond differently. Now this is from World War. So Ward 1 and Ward 2. This is just an example of how attitudes of the patient can change the responses to what we do. Now, Ward 1 had patients with very minor injuries and they were going to get soon better, little minor things. Whereas Ward 2, they had broken their whole limb or they were completely incapable of doing anything. Now they found that the pain of patients in Ward 1 was very difficult to control. We would think intuitively that minor injuries it should be easier, whereas gross injuries it should be more difficult. But the other way around, they found that the gross injuries responded to pain management much easier and earlier, they were quieter, whereas Ward 1 was more difficult. Now, when they went to the root cause, can you guess some reasons as to why this could be? Yeah?
No, I
Can you
feel
have this?
see diseases they can be cured by medicine as well as by positive mind. As doctors, we'll be giving drugs, but they should have that mind that they can be cured.
Yeah.
So we can see that in Ward 2 they are playing game. So it's fine.
They are playing games because their pain got better. I am asking you why uniformly in Ward 2 the pain got better. They are able to play game because they got better. They had the chance of playing that even in Ward 1. So here there was a uniform differences in response, not individual. So is there any suggestion, please? Louder.
Maybe because in Ward 2, as it was previous, they focused more, and in minor injuries they just
No, they were given equal focus. Yeah.
The people in Ward 2, like they must have been sad, but there was nothing to worry about because now they knew and even everyone else knew that they couldn't continue in the army.
That was the reason. They knew that war was over for them. They could go back home because now they were not going. These other Ward 1 soldiers, they knew that as soon as they get better, they will be sent back to the front. They had to go back. Their war had not ended. So they found that was the root cause. So you know what the disease or illness means to the patient is as important to our dosing of medications, especially in subjective experiences like pain. So we need to be not just looking at action, but you learn a lot of anatomy, physiology, all that is very important. At the same time, never forget to see who you are treating. There is a very famous quotation, it's more important to know who has the disease rather than knowing what the disease the patient has. So this is an important message. Now moving on with our talk. Now Ahmed, we talked about him in the first slide, where he is bedridden. He has, once the patient is paraplegic, they don't have sensations, they start developing pressure sores because when we are sleeping, we turn here and there, so the pressure gets distributed, whereas the paraplegic is unable to do that. Then they also have these catheters for passing urine continuously there, and that becomes a foreign body, it gets infected, so there is repeated urinary infection. There is severe pain because of all these things, and because of the recurrent fevers, and the bed sore starts getting infected, and there is a foul smell coming. So in general, he will be so distressed, and for even passing motions, he will be worried because he needs someone else to clean him up. So it's a terrible state of being. Now, is there a place for such a patient in a hospital, even as a general and a huge hospital like this? Paraplegic, after they try out all the surgical methods and correcting the thing, if it is not going to respond to that, he will be discharging them home. What happens to them? Now, this young man can live his whole life because paraplegia is not life-threatening, it's life-limiting, but it is not life-threatening by itself. How does a paraplegic die? Any guesses? Do they die of paraplegia? It doesn't harm their life at all. They die because of generally septicemia. Because either from the urinary infection or from the bed sore infection, the disease spreads to the blood, that is called septicemia. And then the person dies of, complete that response of the hemodynamic failure due to septicemic shock. Now, is that something preventable? Do we have enough knowledge to prevent bed sore, to treat bed sore, to prevent UTI? We do have. Except that we don't have systems in place. Now when you become doctors, you will create those systems. So that is why I am talking to you today. Because it's not rocket science, it is just simple humanity. So now this patient, Ahmed, he will not have a course like Ashish. He will have, he had that injury, then he has, suddenly dropped in health, and each time he gets ill, it comes back, but he's deteriorating. So very often paraplegics don't live through their normal lifespan. They die early, by the time they are 30. Usually all this happens to very young people. Those who are on motorbike or those who climb trees. So all paraplegics, if you see that around 80% of them are young. But they don't end up having a lifespan of normal youngs of that country because of lack of chronic care. So these concerns, Ahmed had physical concerns, he had emotional distress, he was isolated and lonely, that is social. And then why me, why this happened to me, why did, what is the point of living like? Those are called spiritual concerns. So all these dimensions of, distresses exist in Ahmed. Now can we do something about it? This is, also touched upon the WHO definition. So now, all this has been, everyone across the globe thinks these are all important and it is coming into the forefront. So in 2018, the Lancet is a very famous journal, medical journal, which is accepted as one of the most premier journals in the world. And they had a commission to look into this serious health-related suffering because that was missing out from the mainstream conventional medicine. And you see that iceberg I have put there just to show that much is what is obviously handled by our care system, and the whole submerged portion of what are their emotional issues, what are their social concerns, distresses, spiritual, all those are not looked into. Now when you have an OPD of say 150 patients coming in, rushing one after the other, it may be difficult to do if you are doing it yourself. But if you believe this is important, you will create a system. While, like for example, right now I'm working with the nephrology department here in KEM. They have, I think, 100 plus patients walking in during the dialysis OPD. So all of them are in chronic renal disease. They have problems. So what we have done is we have a volunteer sitting in the waiting room with a list of questionnaire. So each patient, the volunteer will go through, because anyway they are wasting their time sitting in the waiting room. Doctors are all in the consulting room. So the volunteer takes in all their concerns, whether it is mild, overwhelming. So there is a list of concerns and it is ticked. So we get that paper in the consulting room, and so we know exactly which are the overwhelming concerns and we can focus on that. So patients' priorities get addressed. So you don't have to say that I don't have time, I have too many patients. You can say that this is important, so I will create a system. It may be something else in your clinic or wherever you practice. But a surgeon will not say it's painting and draping, cleaning the part is waste of time. He will create some system where somebody is doing it. If he is busy, he will come in after the patient is draped. But he will not say cleaning is not important because I am a surgeon, I will just jump in and do surgery. He has considered it important, so he has created a system. So same way, this is not as obvious as a surgical wound, but it's a wound. We will be doing the wrong things if we don't prioritize patient care. We prescribe something, patient will not buy it because he may not have the money to buy it, or he may think that's not the important part, this is what I wanted and doctor didn't address it, he may not come back to you. So it is important to get in rapport with the patient to get all these serious health related suffering. They are called SHS and we are preparing a SHS tool now, hopefully it will be implemented soon. So this burden at the physical, emotional, social and spiritual levels. Now if I ask you, I'm showing this glass of water, what is the question you think I'll ask? No, I will not ask that. That is why I put it up. This is not a question. This is the question I want. How heavy is this glass of water? Yes. Pardon me? Excellent. It depends on the time you need to hold it. If you want to hold it for a few seconds, anybody, a child can do it. If you have to hold it for 1 hour, it will be so tough. You will say, I want some. If you have to hold it for a day, it's impossible. Now we need to remember that all these, we have a toothache for 1 day, and it is so severe we take off and stay at home. Now these patients are having these distresses not for a few hours or a day. They are having it for months and years together. So the burden of symptoms becomes all the more intensive because it is continuous, unremitting, And there's no one, no doctor is interested. They are just interested. Okay, can I do some surgery and correct his spinal cord problem? Oh, I can't correct it, so nothing more to do. He was told, Ahmed was told, there's nothing more we can do. Or somebody with a some other issue, like cancer, is not responding to the chemotherapy. Okay, I don't have any more things to offer you. You can go home. So there is no place for these people. They are holding it on their own forever. So this caring, if we remove our focus just on cure and expand it to include care, we have enough knowledge to help them come out of these issues. So having unaddressed symptoms is like holding this glass forever, every minute of the day. And relieving these symptoms can greatly improve their quality of life. So that is one of the most important principles in caring. Acknowledge, identify their most important distresses and do something to respond to it. You may think it is so obvious because you are fresh from the community. But as you go through your medicine, you will realize that this is often not noticed. Main focus will be, which is important, is diagnosis, treatment, the prescriptions. Okay? But there are so many other things which are also important to make that into what is suitable to the patient. So this brings me to the definition of palliative care by WHO. It is an approach that improves quality of life of patients and family. Here is the one field which includes family along with patients. In most other fields, they are looking focused on patients because we understand that in chronic care, when the patient comes to OPD or to IP, we will be spending 5 minutes with them. We take a round, discuss what is required, prescribe and go. Even in the OPD, the same way. The rest of their lives, after they are discharged or after they leave their OPD, the family is taking care. So unless the family is empowered and for example, I do a fantastic dressing of the wound and make it clean and tidy. And what do I do when I am doing that dressing? Sab log sage wale bahar jao. So everybody is outside and I am doing my dressing. And then I will discharge the person and tell them, this is the cream to be used, this is the solution you have to use for cleaning. They haven't even seen it once. And also what we think, of cleaning and all is we do it every day, so it is okay for us. But for them to pick up that BTD, clean it, and put, it's a very difficult thing because they have never done it before, they have never seen it before. So unless we give them some chance of watching us do it, and also give them a chance to do it once or twice in front of us and correct them, they are not going to be able to go and do that at home. And they have to do that every day, right? In a healing wound, you have to do it till it heals. And in a non-healing wound, you have to do it forever. Okay, so then the patient comes back with maggots inside. And then you scold the family. What is this you have done? You are not taking care. Don't come back to me. But have we done anything to help them take care of the patient? So, these are the things, that's why we include family. So, we call it life-limiting illness. I told you, paraplegic is not a life-threatening disease. It's a life-limiting. This quality of life gets affected. Whereas cancer can be life-limiting because the lifespan can get affected. So, both are considered life-limiting. And we need to prevent and relieve suffering. For example, in Ahmed, we can prevent pet sore from coming, we can prevent the urinary tract infection from coming, but if it has come, address it early and treat it. Early identification, impeccable assessment and treatment of pain and other concerns, physical, psychosocial and spiritual. This is the definition. Any questions on this? So this is the essence of palliative care. It's an approach. You don't, so it requires both science, competence, as well as it requires skills and it requires, very importantly, attitudes. So the first few slides I spent time on attitudes, and now I'll just show you about what exactly is palliative caring about. So we brought this in the first few slides. So it all begins, like for example, if I give you Narendra Modi as a patient, you will be very careful. You will know exactly how to talk to him respectfully if you have to deal with him. Everywhere you will be the best person you can ever be. But if I give you some kind of a prostitute, for example, from the street, the way you will treat that person will be very different. Because you will have your judgment, you will have so many other thoughts which are coming, which will prevent you from showing respect. So the first thing as a doctor is to respect the human being in front. Otherwise, we are not going to be knowing what their priorities are, because we will start judging them. This fellow, he's saying his pain is severe. I don't think so. He's so comfortable. Because in chronic pain, most of the things that you see in acute pain disappears. For example, in a patient in casualty who just had a traffic accident, acute pain, he will be howling, he will be crying, he will be sweating, and you check his pulse and BP will be high. So you know that he is in pain. But if a patient with cancer is sitting next to him, and you ask this traffic accident person what is his pain score, he will say 10 out of 10. There is a score, okay, which you will learn later. I think in physiology, maybe we'll have a class later. Then you ask this cancer patient, what is your pain score? He's also saying 10 by 10. And how does he look? He's quiet. You check his pulse and BP is normal. He's not sweating. He's not crying. So you say, what 10 by 10 pain, and he's so quiet. But what happens is the hemodynamic changes and all the other autonomic changes, they get deconditioned over time. In the sense, they all disappear. What happens is this patient will talk less, he will move less, because every movement is painful. He will sleep less. And all this you cannot do, we cannot judge in a 2 minutes of consultation. So we will miss the whole thing. And so we don't believe the patient. And if it was, again, Modi having, saying that he's having 10 by 10 pain, you will start believing, you will not question that. But if it is some person whom you don't feel that much of regard, you will change your way and say, this person is, just making up something. So everything, the attitudes begin with respect and regard for the person sitting in front of you, who has come to you for help, and they are going to agree to what you want to do. You will say you want to do a surgery, and you give us informed consent. You will say this can happen, that can happen. You may die on table, but sign. That is what they do in consent form, in surgical consent, for example. So why does he sign at the end of even all those cautions? That you may even die on table. Why do you think the patient signs a consent form? Have you ever seen a consent form as a relative or anything? No. Okay, so this consent form is very, very protecting of the hospital and the patient, and the doctor. So, we are going to do the surgery, but this can happen to you. Your limb may go, your heart may stop, you may be put on ICU, you will die on table. But, we agree to all these consequences and they sign. That is what we do before every surgery. Now, why do they sign? Someone said, hope. What are they hoping for?
Survival.
That we will do things in their best interest. So they trust us. You understand? So we need to respect that trust. And so we need to respect the person and do whatever we can in their best interest. It's not that, I have this piece of paper, so I am protected in the court. If we have that kind of an attitude from our side, it's not going to, you will always be, in this world, that will also work. But inside of you, how you feel as a doctor will completely change when you respect their trust in you. And then you respond with equal trust, that yes, I am trustworthy. I am going to do what is best, what is in your best interest. So that is where attitudes come. This is a way of, when we, this is just because, you all are just starting your careers as doctors. I thought it would be good to bring this. This is an important, a study has brought this way of approach to any difficult situation. So they call it GRACE, okay? So suppose I have a patient and family waiting in the next room where I am supposed to give them the bad news that, you are no longer responding to the therapy. Now, we are not going to be able to continue this treatment. It's a very bad news. Or that you have a cancer, or anything that is a bad news, which will make tremendous impact on them. Now, I cannot just, walk with them in the corridor and say, okay, now you have cancer, these are the next appointment. It is terrible. We as doctors, we need to create that kind of private space. Now, in a KEM hospital, you will not get a separate room, but you can always get a corner. and we should sit down. And before going to that room itself, we need to gather ourselves, suppose I was busy doing something or I just finished communicating with some other patient, I should, in my head, I should say now I'm going to this particular aspect of my work. So that is like gathering the attention for the next thing. In here, we also have to look into the chart and get the update before going to the patient. After that, if you're going to search, kya karna tha idhar, that doesn't work. We need to create that attention. Reflect on why we are here. Now, all of you are here because you wanted to be doctors. Now, why do you want to be doctors is an important question, right? And soon, this disappears from your head. It will be more to do with finishing this test, getting this exam done, and many other things. Always recollect why you chose to be a doctor, because that will ground you. Can you give me some reasons as to why you chose to be a doctor? Why did you choose MBBS? Or secret? Nobody wants to share. Even if it is to go to the US, it's fine. Because I see that in interns, 90% are writing US MLE. They want to go abroad. But finally, even after going to the US, we want to become a doctor for some reason, right? Yeah?
Curiosity and interest for the subject.
Okay, curiosity and interest for the subject of human health and
health sciences.
Human health. Okay, that means some interest in human aspects of living. Fine, that is fine. Anyone else wants to? Yeah.
So that I can treat, and the thing is, my grandpa and my uncle passed away few years ago. So my uncle basically passed away because he did not get immediate health care. So my uncle was not able to survive at that moment, but I can at least save someone else's uncle or other relatives and all.
So you want to save lives, you want to do good for as far as health is concerned in the community. So there are
the satisfaction which we get in this field we cannot get in any other field.
Excellent. So for fulfillment and satisfaction of making someone feel better.
To take care of myself.
To take care of yourself. How?
Any diseases I can know it.
You can handle yourself. Okay.
Patient ratio is very less in India, and as my dear one has died due to that, so I want that I should serve this nation by being a good doctor, so that other needy one can't be die due to this problem that doctor to patient ratio is very good.
The dearth of doctors in this country has prompted her to be a doctor, so that the ratio that the patients have for access to healthcare improves. Excellent reasons. So please get back and so the R stands for in the grades, reflect on why you chose this profession. That gives you some kind of a zero and some kind of a strength within you to go and meet a difficult situation. Because some of the doctors who have not got that centered, they try to avoid difficult situations. And so that should not happen. And attune, so get familiar with the patient's records and what he's going through, etc. And then the interactions begin. In the interactions, consider what is most helpful, and then explore, engage, and also exit nicely. Exiting should not be you understand all the problems of the patient and say this is what needs to be done. Always have an exit of when I will see you next. This is your follow-up day. And if there is anything, you can contact so and so number. So there is always some kind of a continuity in your interaction with patients. So there is this grace which can come into use for any difficult interactions. So skills in communications. So there is listen and then listen a bit more. There is no end to how much a doctor should listen, because each time you listen to patient, they are actually telling you their problem. You don't have to do multiple choice questions there. They will tell you one symptom with the other symptom and the third symptom, and then all that you have to do is associate it based on what you learned during these few years of MBBS, and then the patient is really telling you the diagnosis. So if we listen well, we will be able to help them. And of course, you have to build the knowledge and the capacity to treat them. So there is knowledge involved, skills involved, and the attitude. I have mentioned communication skills here because That is special, different. There are other skills of surgical skills, procedural skills, many other skills you will learn, to do procedures on the patients. That is different. So this is health-related quality of life. When someone like Ahmed has good symptom control, he doesn't get fevers, he doesn't get pain or bed sore, he is able to be usefully functional. He psychosocial, like he's depressed, why am I being alive, I should be dead, that kind of feeling should disappear. And life becomes meaningful. Then we have improved the quality of life of Ahmed. Now how do we do that? Let's look at it. So we do, of course, the grace, and this is what, this is same Ahmed. So this is a nurse who went to his house. So you can see that in the earlier slide, he has a bed. This is a water bed actually, but it is not being, used properly because somebody donated the water bed, but so it is there. So it is all, folded, and that is itself can cause bed sore because the folds can keep increasing the pressure. So first thing he does is make the bed proper, the air bed. Then he teaches them how to use the water bed. So his mother is there, and then of course we manage the bed sore, and then we taught them how to prevent it, how to use the body massage, how to not use the powder, because people put a lot of powder in a patient who is bedridden. Then what is CISSC means? Clean, intermittent, self-catheterization. That is what is the state of art, not continuous urinary catheter. Because continuous presence of a catheter can cause infection. But the patient, he is a male patient, he can just use simple catheters and catheterize himself at the interval that he needs to. His hands are okay. So that is not sterile technique. It is called clean, intermittent. Just he has to wash hands and the catheter, use it, remove the urine. So he is free. Just like how we use the bathroom, he can use CISC, which is again, not something that is routinely taught, but I request you to learn because it can help a lot of bedridden patients. So this will prevent the UTI. After you treat one episode, we want to prevent it. For that, we have to take out the permanent catheter and then teach the intermittent self-catheterization. Physiotherapy and function, because whatever is left, the power, we need to enhance it. So he is able to use some wheelchair. There are techniques of, like for example, in his home, what he did with the physiotherapist did was he tied a rope with a knot which he can reach from his bed. So using that knot, he can sit up himself. He doesn't need someone to come. So it's very simple things. And also, we teach them how to turn by themselves. Because all these can be done by just slight modification of the environment. And then how to move from the bed to the wheelchair, from the wheelchair to the bed. All this can be done. So they become independent. And also removing, there are these thresholds between rooms. So the house can be modified by getting rid of those, what is threshold, right? That elevated thing. So disability, when they are using wheelchair, that will be a block. They are not able to move even within their house. By just removing that, he becomes mobile within the house. So you can see that little things, it's not really huge thing. Just look at the patient, understand his priorities and add value. So, and economic. After this, now he's fine. He's not having fever, he's not having pain. Now he says, I want to do something and earn money. So he was taught jewelry making. So, he started selling this jewelry that he made. And, how the life changes for the same person. So, we cannot say there is nothing more you can do. Now, you will say that I am a doctor, why should I look into all this? It is not that you are going to teach jewelry making and thing. But if you have this as an important part of your patient care, you will have a list of NGOs who do these things. So, you can refer the patient and family to them and they will do it for you. It's just that you need to initiate these aspects. You will have to refer to the physiotherapist. You will have to refer to the psychologist if required. But you need to understand how to use these multidisciplinary teams. If I think that I am a doctor, I know everything. No. We know much lesser than what a physiotherapist will know about rehab, what an occupational therapist will know about the home environment, or a medical social worker will know what are the funds available in the community. So please use all the disciplines. All these disciplines exist in this hospital. But keep a watch as to how well they are utilized. And if you think it is well utilized, follow it. If you think it is inadequately utilized, change it when you start practicing. That is what my intention is. Okay, so we not only assess and advise, because that is where usually our conventional medical practice ends, we agree with the patient as to what is most important and assist and arrange for it. Okay? So this is the WHO's principles of chronic care. The 5 A's they call it. Assess, advise, agree, assist, arrange. Okay, now we'll talk for a few minutes on death. Because palliative care, when spoken, most people think of it as end-of-life care. But you saw very well in Ahmed, we are just actually allowing him to complete his normal lifespan. So, when our patients die in our hospitals, okay, option 1 is that they go to ICU, they are put on ventilator, when the saturation drops, when the pulse drops, BP drops, this is what is done. Or if the kidney is failing, dialysis, etc. Now, this particular way has now become a routine way of dying. In fact, if I don't want this, I have to write a will. It's called advanced care, it's called a living will. Otherwise, anyone who's my friend will put me into an ICU and ventilator. I don't want to die like this. Anybody wants to die in an ICU on a ventilator? Very sure? If I give you the best, trained intensivist and the US returned doctor in charge, would you? We don't want to. So same thing, it is not just us. Everybody, nobody wants to die in an ICU on a ventilator. Okay, so please remember that. Then very often we refer them because we are uncomfortable watching. We don't know what to do, so we refer them. So please understand that it is one of the most impersonal, sterile, mechanical and isolated way of dying. The relatives are sitting outside the classroom, without having anyone to talk to. The patient, he may be conscious, may be unconscious, but all that he's seeing is some masked faces, some beep of machines, and we don't know what is day and night also because everything is all the time lit. And there is nothing soothing about being in the ICU, and very often we are paralyzed, inadequately sedated, there are a lot of issues. And also the cost, we should never forget the cost. So this is a study which came out in the Disease Dynamics Policy. 63 million Indians are pushed into poverty only by healthcare expenses. Because one day in an ICU on ventilator can go up to a lakh in a private hospital, and here it may be even 25,000, I'm not sure. So it's a very costly affair. So we need to justify if we are expecting the patient to pay for something. Is it good? And they are thinking, families thinking patient is going to walk home at the end of it. Because we have not communicated the right things. So this is not only for poor patients or uneducated. Now, Parthasarathi Shom is advisor to the Prime Minister's office. Okay, so he lost his mother in 2016, and he wrote an article in the Business Standard, the magazine. So he has written like this: I could give no choice to my mother, who pleaded to be taken home. Such was the pressure I felt from the specialist in the ICU to apply the last available technique, despite the emaciated body in extreme pain. Now, was he illiterate? He was very educated. Was he powerful? Extremely. He was, connected to politics also. Even on the day of passing, a specialist recommended a procedure. When I asked why, it was informed that it was their responsibility to do things as per protocol. So he asked one question: where was palliative care? Because if you go to 100 hospitals in India, maybe one will have it. That is the level of care component in our healthcare system, and you all are 250, I heard this year. So you all are going to create at least whatever you do, be it a general practitioner, an ophthalmologist, or a surgeon, or cardiologist, or whatever you become, or as she said, she wants to go back to the community and start practice as a general physician. Whatever you do, always treat with care. That is something I hope this lecture will take you to. So the other options also exist. We ask the patients to go out without giving them discharge summary. All this you will see, they call it LAMA, leaving against medical advice, because we don't want to take responsibility for their discharge. The family is supposed to leave without taking any notes with them. So all these are tricks we play because of the power hierarchy. We are always much more powerful as doctors and hospitals, and the patients feel, they don't have the power to question what you do. So we need to bridge that gap. So this is one of the worst places to die. This is the report from the Economics Intelligence Unit report. India is one of the worst places to die. And if you see here, they made an index of 80 countries where the quality of death index, and we stand at 67th. And we were 2 years earlier, they did a survey of 40 countries, and we were happily the 40th on the countries. And this happened only because, like Dr. Amit said, we managed to change a law, the NDPS Act, and so the access to essential narcotic medications. So that policy change brought us a few steps up from 80 to 67. Not great, because you can see that very other similar low-income countries are above us. Mongolia and some other countries are above us. It's not like only the Western countries which are rich are above us. So I think, okay, this last slide I will talk on, effect versus benefit. When we do any intervention on patients, it may change serum creatinine, it may change, say, their saturation, it will improve their BP. They are called effects. Effect of what we do to them. Whatever is, some drip that we give or some injection that we use. Benefit is that the patient has the capacity to understand. Like, patient is able to stand up, patient is able to go and cook for the children. Whatever it is, they should know that by doing this treatment, I am going to benefit in the manner or in the way I live. So, effect is a parameter or an investigation. The CT scan shows that tumor was this big, it has become this big. That is an effect. But has it helped the patient go back to work? That is the benefit. So always differentiate effect from benefit when you are treating a person, and see whether whatever you are doing is benefiting the person. And for that, you need to talk, you need to listen and prioritize their care. Okay? So I end here because I think even few questions would be worthwhile. It will be more important than completing my slide. So does the class mean it is ended, or we still going to have questions? Anyone had experience of caring for some loved one who was chronically ill at home, and you had no place to go and ask for help?
Ma'am,
Yeah.
what is exactly done in palliative care?
Okay. So what is exactly done in palliative care? So as I mentioned, we listen, we document the patient's priorities, which will include physical concerns, which could be pain, breathlessness, nausea, vomiting, constipation, inability to do, I can't walk, I can't get my voice out, whatever it is. Then we also evaluate, we have tools to evaluate how are you feeling. Like, when somebody says, this happened, the next thing that we usually ask, then what did you do? Then I went to the doctor, then what did you do? He suggested this surgery, then what? We also ask, how did you feel? So, along with what did you do, we also ask, how did you feel? So, we have also a feeling of what they are going through. And suppose they say, I am not sleeping well. It's easy for me to write a sedative. Okay, with this you can sleep. Or I can ask, okay, exactly what happens when you go to bed. Is it some thoughts, intrusive thoughts that are affecting you? Or are you sleeping late after going to bed? Because that means anxiety. Or are you waking up suddenly at 1 o'clock? That means depression. It's not like, I'm not saying that this is an absolute diagnostic thing, but then I can ask further. So insomnia, difficulty in sleeping, is not just treated with another bullet tablet. We try to understand, we try to give them sleep hygiene techniques, etc. So that is all about the physical parts and emotional. Socially, we ask them, like suppose we suggest dialysis as a treatment modality. Are you able to reach the center? What are the difficulties you have? And it's not that, this is not actually done by me, but it will be there in the questionnaire itself. So we will connect the person to the right unit, because now government has also started multiple dialysis units which the patient may not know. So accordingly, we will refer the patient to the appropriate, which is more accessible, and maybe the person can only come for some reviews into the nephrology unit, like that. and then spiritual. Because once we develop a rapport and help them relieve their pain, or they are better, their breathlessness has improved, then we start asking about, do you have questions about, do you ever think why this has happened to you, or what is it that I need to know about you to care for you better? This is not my own sentence, it is called the Dignity Questionnaire. It was designed by a Canadian doctor called Chochino. What is it that I need to know about you to care for you better? That is called the Dignity Question. Okay? So these are the questions that we can ask once we develop a rapport. Then they may come out with something else. Actually, I know that my time is limited. Maybe I will not be there after 6 months, but it is very important for me to go to Velangani church or to some dargah, whatever. So then we try to discuss with the family, facilitate that, or it may be simply that I want to spend more time with my grandchildren. So we need to understand those aspects. So we try to connect. Some people, they want to see their child married. So maybe there is already an engagement. So sometimes we have facilitated engagement ceremonies in the hospital where he's, so that there is some remembering exchange. So there is a sense of completion that I have done my duty. He feels that now, okay, even if I go, it's okay. So those little things, it's not too much of effort, but it's more of engaging and listening. So we try to look into as much as possible. Some of them are having no best answers, but some of them we can do something about. Thank you for that question. Okay.
Any more questions? May I call Lopamata madam to please come on the. So, as you could see that this is an entire, it goes beyond your call of duty also, and this is the difference between care and cure.
Very much in your call of duty.
Yeah, but I mean, not that everybody. I request look. Yeah.
Very good morning.
Good morning, ma'am.
And I'll tell you something, I was so thrilled today because in 1963 there was no concept of anything of this kind. We only started with information. Now the whole scene is so positive. I'm sure India has better future with all these students. I'm growing with all of them, so it's very pleasant. This is a theatre. I've seen someday when we have time I'll talk about it, what things have changed here from 63 till today and how things have changed. But please bear in mind what you are getting are really nuggets to make your life fulfilled. Don't ignore this. Information will be able to load yourself as much as you want. But this pearls of wisdom which comes with experience, you won't get. Thank you.
I request Lopamata madam to please felicitate.
Thanks. All the best. Do it.
Thank you, ma'am.